I'm going to talk about addiction treatment today. And I think next slide, I don't have any conflicts. And then, so today you're going to review the DSM criteria for addiction and a little bit about getting a history and sort of why we're doing that and a few tips on that. And then talk about the patient placement criteria. This is a system where you can decide which kind of treatment patients might get. It's actually quite relevant in the provision of addiction treatment services because those services generally need to document why they're putting patients in a particular level of service, and insurance companies care about it and stuff like that. So it gives you a little bit of an idea of what goes on behind that black box of opiate of any kind of addiction treatment. And then we're going to talk, because it's more relevant to the pain world, opiate addiction treatment with methadone and buprenorphine. Next slide. So the DSM-5 has criteria for substance use disorder different from DSM-4, where we talked about substance dependence and abuse. And this is the list, and it's really, because it's such a long list, I think it can be a little daunting in terms of getting the history. But what we're looking for are primarily some physiologic things, tolerance and withdrawal, but then mostly consequences related to use, whether they are personal, that they want to cut down, or that they're spending a lot of time using or recovering from use and using more than intended, and then other more problems broader in their life, whether it's physical, psychological problems, or role problems that they're unable to fulfill. In these new criteria, there is a new one, craving. You would have thought maybe it would have been in the old version, but it wasn't, but it is now. One way to ask that question is such a strong urge that you could not think of anything else. And then legal problems actually are no longer a criteria in substance use disorder. So so how do you get this information? You can do a checklist, but it's kind of odd to do that with a patient. Next slide. So getting the history, I like to tell me about questions because that gets the patient talking and you're shutting up, and you can nod, and you can also pick out things that they say when they're telling you about that and ask them to say more about it. So it's always a good history when it's mostly coming from the patient. You're doing a little talking. And when patients, I think it's pretty common that patients, especially older patients, have had a history of drug or alcohol problems that in the past that's been more significant. You definitely want that information. So if patients say, oh, I'm doing fine with my alcohol use, or I drink a little bit, it's not a problem. You can ask about, tell me about your use in the past. Did you ever use more? I think it's really helpful to get the history from the beginning, because often it's an adolescent onset disorder, and if there's a problem, that's when it's going to have emerged most likely. And you can talk more about it, and then talk about how they've changed it, how they've improved, how things got better, and you can give them a lot of feedback that's positive. And I think that sets it up where there's rapport and you're going to get much more accurate information about what's going on now, and if you know the context for what happened before. So you're listening and reflecting about any problems that they had, any reasons that they had to change. That's if they're not drinking like they used to or not using like they used to, why was it that they changed, how they did that. Lots of positive feedback and encouragement for that allows for better disclosure. And then if anybody's had treatment, you really want to go after what kind of treatment that was, how long they were in it, and how long they stayed sober after the treatment. And then where they are now. If they feel everything's fine, they may not be ready to make any changes, but you're going to want to assess that as well. So that you can end up getting those DSM criteria through this approach, and I think it's a little bit more a natural conversation. Next slide. So the American Society of Addiction Medicine, that's what ASAM is. They've developed some patient placement criteria that really are aiming to assess patient needs so that they can recommend the right kind of treatment in addiction services, and it is a very broad assessment. So there's bio, psycho, social dimensions, there's severity, there's sort of where they are in terms of their trajectory and treatment, and it really individualizes care. It also allows you to say this person meets criteria to need outpatient treatment or intensive outpatient treatment or inpatient treatment or whatever the services that are being proposed. Next slide. So there are dimensions within the patient placement criteria, and these are, I think, helpful to understand. And as you get better at taking a history of someone who has an addiction issue, these things start to become more part of the wallpaper of what you're looking for when you're meeting somebody who has a problem with substances. So there's the kind of things that we're maybe more used to in medical setting. How bad has their withdrawal been? And that obviously guides some placement and treatment. If somebody's had terrifically bad withdrawal, they're more likely to need more intensive support around that withdrawal if they're going to go through it again. Medical complications we also deal with commonly in the medical setting with, we think about liver disease, we think about infections, and we see a lot of those as consequences of drug use or alcohol use. So that's another dimension along which you need to assess what other kinds of treatment they need along with their addiction treatment. And then the emotional, behavioral, cognitive, these are things that we think about as psychiatric diagnoses that can be really important to treat along with addiction. Many people with psychiatric disorders, that's how they start their drug use, as sort of self-medication. So you might not be able to tell that right away, whether there's a primary disorder or like a depression disorder, and then they were medicating that with drugs, or if the depression may have come on after or as a result of the drug or alcohol use. So that's you need to understand how severe those symptoms are, whether they're substance induced or not, and then over time you're going to need to figure out whether there's a primary disorder that needs treatment. And then the next dimension is readiness to change, and this can be anything from, oh my God, doc, I need to quit smoking or quit drinking or quit using drugs, to someone who's mandated for treatment because of a DUI or through drug court, and that they may be also ready to change, but there is an assessment there and trying to understand where somebody's at in terms of their readiness to change. Are they ready to change all substances? Are they ready to stop shooting heroin, but they really would like to be able to continue to use stimulants? That's a whole dimension that needs assessment. And then relapse potential, the next domain, is really a lot about where they are, about what they're doing now and their current use, and how risky it is, how many symptoms they have when they're coming off, and sort of how likely is it that they're going to have trouble with relapse. And then the recovery environment relates to that, but is also broader in the sense that people's safety might be an issue, or but mostly it's, are you living with somebody who's using, or are you not? Do you not have stable housing? Because those also play into what kind of addiction treatment you might need, especially initially if you're homeless and really out of control and there's no way to change that, then inpatient treatment may be a necessary first step, even though it's not not necessarily a solution to the problem. It's not an acute disease that you're treating, but it may require that acute treatment as an initial step. Next slide. So the levels of addiction treatment, and these are the ones that come straight out of the patient placement criteria, are listed here. And there's outpatient programs, there's intensive outpatient programs. Usually that intensive outpatient is quite a lot of treatment. It's about 3 hours, 3 times a week. In this part of the country, we don't do much in the way of partial hospitalization, where people come like a half day every day. Those programs do exist across the country, but not so much here. So if you're going to do outpatient treatment, it's mostly going to top out at sort of that 3 times a week kind of. And then outpatient is anything less than that, anything from going once a month is sort of a relapse prevention kind of thing, or something more intensive than that. Residential programs, inpatient programs are what they sound like. You're no longer staying where you used to stay, and residential programs tend to be longer. They can be 6 months, they can be a year, they can be indefinite. So. And then medically managed inpatient is mostly related to the risk of withdrawal and acute problems with medical or psychiatric problems that are acute and need management right away. And then there's a whole other category outside of this four-level addiction treatment, which is co-occurring disorders, meaning addiction and mental health problems. And so each program will have some range of services that they can provide. Some just do addiction. Some have what they call dual diagnosis capable. In other words, they can manage a depression or an anxiety disorder, but not so much a severe mental illness. And then dual diagnosis enhanced would be a full dual diagnosis kind of program where severely mentally ill people who also have addiction can get care. And that can be any of these levels, right? So the inpatient program or the intensive outpatient program, those can be dual diagnosis capable or enhanced. And it may be important, but it's not something that a primary care doc tends to figure out. They mostly send somebody to a person who can do an assessment. But this is the kind of thing that person who's doing the assessment is thinking about, both the dimensions of addiction and then what level of service matches their need. Next slide. So in primary care, there's definitely more interest now in integrating addiction services. So, and this is outside of that ASAM patient placement criteria system, and so hasn't been fully incorporated into that system. So we're talking about doing addiction treatment in primary care, and the basis for that is a lot of work that's been done mostly around alcohol and unhealthy alcohol use. So people who have unhealthy alcohol use but don't have an alcohol use disorder, they could be effectively treated through screening and brief intervention in primary care settings. That's one area where you don't even wouldn't even be eligible for an addiction treatment program because you don't have a drug or alcohol use disorder, but it can be intervened on in the primary care setting. The other setting which is getting, or primary care treatment model that's getting more play, is medication management models for alcohol and for opioid use disorder in the primary care arena. And that is based on a lot of work that's been done, that when you actually end up prescribing medications for substance use disorders, that adding a lot of specialized addiction treatment on top of just a regular medical management like we would do for hypertension or diabetes doesn't really add a whole lot. So once you've taken that step to medications, it's not clear that you need to be in a specialized addiction treatment program if you're able in the primary care setting to provide enough support for that patient. And how much that support is not well defined, but usually at most every week or two seeing somebody and then tapering that off as they're stabilized on whatever medication. So this is being experimented with more in collaborative care kinds of programs where you might have a nurse who manages the patient. The doctor doesn't see them that often, but the nurse may do some outreach and may do some counseling, that kind of model. So that's where primary care overlaps with addiction treatment programs, and definitely there's a lot more supportive evidence for this approach. Next slide. So opioid addiction treatment, going through if you have a patient who is diagnosed with an opioid use disorder, and granted that can be a tricky thing. I've talked about that in other talks around the assessment issues, but assuming you have somebody who has an opioid use disorder, and they need treatment, and they need treatment with with medication. They're highly effective medications for this disorder, much superior to doing some kind of detox or inpatient treatment. That pathway doesn't result in success very often. Most people can't even get through a detox because the symptoms are too severe. And if you have there's really a dichotomy between opioid addiction treatment and the rest of addiction treatment. Even though they're specialized treatment centers like methadone programs, the treatment centers that don't do opioid addiction medication management, they have trouble with patients who are treated with opioids for anything, whether it's pain or with addiction. And so a lot of people with opioid addiction, even if they have other addictions, seek their care through medication-assisted treatment that revolves around their opioid use disorders. And definitely, if you have a patient who has a pain problem and an opioid use disorder, then it's really imperative that they get treated with a medication-assisted treatment model with methadone or buprenorphine. And those patients, you don't want to fire them, you don't want to discharge them from your practice, but you do want them to get help. And if you're not in a position to provide that treatment with buprenorphine, you need to get them treatment through somebody who can, but then keep after the pain, because the pain will get a lot easier to treat once they're in addiction treatment. Next slide. So let's see, methadone maintenance. So methadone is the gold standard for addiction treatment or opioid addiction treatment. There's been tons of research over 40, 50 years about methadone maintenance treatment showing that higher doses actually improve outcome, and that's been shown in randomized trials, a number of them. Lower dose methadone is definitely not as effective as doses in the 60 to 100 milligram range, and many programs will treat patients at even higher doses. Really, the dose that is right is the dose that gets people to stop using opioids, and so there really isn't an upper range on the dose. This contrasts with methadone in the treatment of pain, where higher dose treatment is clearly associated with bad problems and safety problems. And even in methadone maintenance programs, there used to be more problems with death in methadone maintenance programs early in treatment until they limited the dose that people could get early in treatment. So that dose has to be started low, like 30 milligrams or even less, no more than 40 milligrams at the beginning of treatment, and then titrated up slowly in order to develop the tolerance that is really the basis for the treatment. Longer treatment, like in any addiction treatment setting, longer duration of treatment improves outcome. You do get some benefit from psychosocial services on top of methadone, but really the medication with methadone is the primary treatment and has the primary effect. You adding really heavy levels of psychosocial services like intensive outpatient does not improve outcome in methadone treatment. And there's definitely poor outcomes with people who discharge off methadone. It's about 80% of people who will be back using opiates within a year. That doesn't mean no one can do it. There's that 20% that are discharged that may have been very careful about how they discharge and taper off very slowly and come at it from a very stable point in their life. But it's usually not right for patients who, especially if they're still struggling with either addiction or the consequences that have occurred because of their addiction. They should not be encouraged to get out of treatment with methadone. And there's been a number of tests showing that maintenance strategies for methadone are superior to strategies that try and get people off methadone. Next slide. So there are some limitations with methadone maintenance treatment. It is a very structured program. Patients have to go 6 days a week. And so it's a high bar for people to accept treatment in methadone because of how often they have to go. These programs often have limited clinical flexibility, limited medical services because of what they're doing, and they sort of have to go by the book in order to make the place run smoothly. And it's also quite a stigmatized form of treatment. You'll have patients who definitely need addiction treatment, opiate addiction treatment, who either have had bad experiences in methadone or don't want to go because of what they've heard. And often there's some motivation that has to be developed around that. And people have to be educated around the success of methadone treatment. And methadone maintenance programs, if you're talking about patients who've been treated with pain, with opiates for pain and have been found to have an opioid use disorder, those patients need to be coached in terms of how to get into methadone. They have to tell the patient, the program, that they have an addiction order, and that's what addiction disorder, and that's why they're seeking treatment. But methadone maintenance patient programs, if they are confronted with a patient who says, I need methadone for my pain and my doc won't prescribe it anymore, those patients won't be accepted into the methadone program. It's also a daily dose, and that might not work for pain, although my experience is that patients who have both addiction and pain are often quite well managed on methadone once a day. They don't have specific resources to treat pain, so that's why it's important, if you are referring patients, that you maintain your pain treatment and your efforts to treat their pain within the primary care or pain treatment setting, even if the patient's going to methadone. And it can be a struggle to collaborate with methadone maintenance programs. You have to get releases signed and faxed, and sometimes it's difficult to reach the physician who might be in charge or the medical provider. But it's definitely worth doing if you can arrange that kind of collaboration. Next slide. So if you have patients who are on methadone, it's important to understand how well they're doing in treatment. And the way to do that is just ask them about their urine test results. Ask them about how they're doing in terms of opiate use. One very good test is whether they have take-home doses, because methadone programs are not allowed to give take-home doses to methadone patients unless they've shown some urine tests just with methadone in them and have made all their appointments for a few months. So they have to have done pretty well to get take-homes. And if they're going something like twice a week or once a week, it means they've been stable for a long time and are doing very well in treatment. And then you can ask about their dose. Some patients who are going every day are resisting a dose increase when it's appropriate, when they're still using opiates, or they may be trying to taper prematurely. So that's another reason to assess the dose and how they're doing with that. It's really important for patients to stay in treatment until their social problems, their medical problems, mental health, and legal and family issues are stable. Methadone programs are allowed to give take-home doses that are even extended take-home doses up to a 1 month supply if patients are doing very well. And this can be an alternative to tapering. And there's some patients who've been in these programs for decades and are working, and they go once a week or once a month to the program and pick up their medication. So that is an alternative to tapering, and many patients do really well with that. Next slide. So buprenorphine is the other medication for opioid use disorder. It was made legal in the primary care setting through federal legislation called the Drug Addiction Treatment Act in 2000. And physicians who complete an 8-hour training and get a waiver from the federal government are allowed to use buprenorphine in their office setting. I've said it before and I'll say again, understanding this form of treatment will help you in your chronic pain treatment skills, and it can be very gratifying. I think many pain providers who've started using buprenorphine have found it to have a really good niche in that mode. Patients' pain can be treated quite well with buprenorphine in many cases, and to watch somebody sort of recovering from an opiate use disorder and the chaos that goes with that can be really great to watch. Next slide. So buprenorphine is, unlike methadone, which is a full opiate agonist, buprenorphine is a partial agonist, and that means that if you give more and more of it, there's kind of a plateau effect where the opioid receptor is not fully activated, and therefore it's safer because you're not going to overdose. Buprenorphine is also given in combination with naloxone, but the naloxone is really there as an abuse deterrent. It's not absorbed when you take take it under the tongue, and it's only if you tried to inject the buprenorphine plus naloxone that you would potentially go into withdrawal from the naloxone. So it's not part of the treatment, it's part of an abuse deterrent strategy. Um, um, the the other aspect of buprenorphine itself, besides being a partial agonist, is that it grabs onto the opiate receptor very, very tightly, so it blocks other opioids, and that's obviously a very important mechanism for opioid addiction treatment. If people are on buprenorphine and try and shoot heroin or take other opioids, pain medications, they just don't get an effect. Next slide. So buprenorphine's been studied not as long as methadone, but it's clear that it's superior to psychosocial treatment, and longer duration is more effective. If you look at the outcomes of patients in buprenorphine treatment and methadone treatment, they are similar in terms of drug use while they're in treatment, but methadone treatment is better at retaining patients. So about a 15 or 20% difference there over multiple studies showing methadone to be better than buprenorphine at retaining patients. Now, that doesn't mean that buprenorphine isn't a good choice, especially for patients who are coming new to medication-assisted treatment for opioid addiction. As your first treatment strategy, buprenorphine is likely the best choice, because if you do well with buprenorphine, you don't have to do the 6-day-a-week thing and go to the a very sort of high bar kind of program. There are a number of issues, and if you're thinking of prescribing buprenorphine, related to just getting set up with the protocols of how you're going to refer, who you're going to take. Is it just going to be patients that you have in your practice who you have diagnosed with an opioid use disorder, or maybe in your extended practice with your colleagues, you may take those patients as well. And there's no need to like put your shingle out and say, I'm an addiction treatment provider, and take referrals from the community if you don't want to. But it can be very useful for your partners, for your colleagues, and for you and your patients, even if you choose not to have it be a substantial part of your practice. You also have to figure out how you're going to do induction and learn about withdrawal assessment so that you can do that, because there is a potential when you're starting buprenorphine for a precipitated withdrawal, and so you need to know that and know how to avoid it. And you have to figure out what kind of psychosocial treatment you might require or can provide in your office. Figuring out about payment and insurance is gotten a lot easier recently now that Medicaid is paying for buprenorphine with much fewer hoops to jump through. And then trying to figure out when you might stop buprenorphine or refer people to other kinds of programs like methadone. Next slide. So if you want to get started with buprenorphine treatment, there's the Physician Clinical Support Network that you can reach through the SAMHSA website. UW Telemedicine Support I'm here to help you, and I'd be happy to talk to anyone who wants to try and get set up with buprenorphine. And just often I think there are some cases with pain and addiction where people might want to refer to an addiction consultant. And I'll just have you pause and consider the possibility that might not be as effective as actually doing some kind of telemedicine support or MD to MD or MD to provider kind of consultation, because it's difficult for addiction treatment providers to see patients with pain and addiction, especially if the patient is resisting a diagnosis of addiction. And it's difficult to get a good story in that setting. And often you've gotten a better story yourself in the pain context and can make a good plan with a phone consultation. So I'll just put in a plug for that. Next slide. So this is just a summary slide. Addiction issues can be really important in pain management, especially when you're prescribing opioids. Understanding addiction treatment system can help you understand what your patients may be going through when you refer them. Effective treatment is available and should be provided, and if you end up trying to provide addiction treatment yourself with buprenorphine, understand that it's a great form of treatment. It can really help you in your pain practices. So I'll stop there, and if there's questions, happy to, or conversation, happy to go through that. The next slide is just about COPE REMS, and I think that's all I'll say. Thanks.